Dr. Resheed Alkhiari. He's an associate professor of medicine at King Saud University, and he's an advanced therapeutic endoscopist. Dr. Rashid today will talk to us about endoscopic management of early gastric cancer. The floor is yours.
Assalamu alaikum. Sabah al khair. It's great to be here. Thank you, Imad, for the kind invitation. It's always good to be here and happy to talk about gastric cancer and early lesions and the endoscopic management.
Sorry, Rashid, if I can ask you and the next speakers, if we can cut it a little bit short for the prayer time, I would appreciate it.
Okay, so how to move this? Okay, um, so why is this not working? So I don't have any disclosure regarding this topic. And a few facts about gastric cancer. It's considered worldwide fifth cause and also one of the top of cancer-related mortality, and it's distributed worldwide. Luckily, we don't have a high prevalence for or incidence of gastric cancer compared to the others. And beside the gene, there are a few factors associated with gastric cancer, including H. pylori, smoking, EPV, and aging, and in addition to the salt and diet low on fruit and vegetables. So usually early gastric cancer usually detected incidentally or looking for other reason of dyspepsia or abdominal pain. And when we diagnose it with endoscopy, we need biopsy, and the staging can be done with different modalities. The early gastric cancer and management does matter, and the early detection is very important because the survival is different. If you detect it early and you remove it, either endoscopic or surgical, this is survival in 5 years more than 50%, and beyond T2 with medication, chemotherapy, it can be a 50 months median survival rate. When it exceeds the advance, when it comes to the advance, usually is less than 2 years if you are lucky. In early gastric cancer, they defined it as gastric cancer that occur in mucosa or submucosa, irrespective to lymph node metastasis, as those lesions that can be missed during upper endoscopy. The indication for endoscopic resection in general, you need two things. First, they have to have very low risk of lymph node metastasis. And the second one, it has to be amenable for endoscopic resection related to the size and the site and location. How to achieve endoscopic resection. As advanced endoscopists or endoscopists, we always think about EMR, but it's not good as we thought. And the question come to us, can we remove it in a block? What about the curative resection? What about the recurrence? And is the size is possible to remove in one modality or others? And here where the importance of the ESD comes. So regarding the endoscopic management, we have two modalities, the EMR, which is classic, most of you know, and also ESD. I'm not here to talk about the techniques itself, but just to highlight the importance. We have 4 guidelines. The first one in 2020, the Korean, the second edition of Japanese in 2021, and also the American 2023, and the European just came this year. An early gastric cancer. And regarding the Japanese, the question comes, can we remove it endoscopically? They have criteria for resection based on 2 factors, the differentiated type or undifferentiated and presence of the ulcer in addition to the size. And the reason why, because if they have ulceration and undifferentiated, the risk of lymph node metastasis is higher, as you see in this percentage. Regarding the American guideline, the recommendation was kind of shy. They kind of differentiate less than 2 centimeters. They cannot recommend ESD or over. They cannot recommend ESD over EMR. You can choose. And when it comes to any undifferentiated type, they recommend surgery. The guideline, the European guideline, the highlights here is similar to Japanese, but they think the rule of EMR here is a lesion that has low likelihood for malignancy, less than 10 millimeters pars 2A. We have different modalities doing EMR here with different techniques, but as I mentioned, it's not as great as we thought. This is a meta-analysis for 4,000 patients. The R0 resection is around 51% compared to 90% in ESD. One of the largest in the history Japanese trial for resection of early gastric cancer. Around 41 hospital institutes participated, more than 10,000 lesions. They achieved 99% in a block resection. With R0 resection was about 92, and with the curative resection was 82. A quarter of them, they spent 2 hours in the procedure, more than 2 hours in procedure. And if you see more than 10,000 patients or lesions, the EMR was only 0.6%. When you think about ESD compared to surgery, there was 2 studies basically checking the long-term efficacy of these procedures. And with ESD, the morbidity was lower, and synchronous lesion was high, of course, because you are resecting only the lesion. And when you think about the adverse event, still with the other study, comparative study, was less, and the survival was kind of similar with no death among ESD cases. So what is next after endoscopic resection? We always celebrate removing the lesion, but what is after that? So there must be a scoring system to give us an idea. Is this patient cured from the cancer or not? And here where the Cura system came, they have many factors and point. If you have, for example, 5 points, probably you have 22% of risk of nodal metastasis, and this is where the discussion with the patient is important, and to send them for surgery. The other question: how can we do better in detection? And this is a prevalence of missed lesion, and it's scary here. It's around 6% in upper endoscopy who miss early cancer. The quality of exam is very important, and the use of AI maybe has a role in the detection of earlier detection. So the other question: how can we do better in surveillance? Metachronous lesions, after resection, we're happy about resection, you are cured, go home, but this is not the end of the story. They will come back with cancer, another lesion, and the cumulative risk in 5 years is around 10%, which is a huge. So the other question is: how can we do better in ESD? And this is a question for Nawaf and Dr. Ahmed, anyone doing ESD. How can we do better in ESD? And my answer, I'll hear your answer after, but my answer: you need 3 T's, which consist of training, and you need also traction, and you need team. So take home message: I think we are missing early gastric cancer a lot. If you have 6% in a good study, good quality of endoscopy, I think we're missing more. EMR is not good as we thought, and early gastric cancer does not end with the celebrating the lesion, removing the lesion, and you need 3 T's to have successful ESD. Thank you very much, and this is our team. I hope it was in time. I'm not.
You gave us an extra 6 minutes. Thank you.